Good morning, everyone. Good morning, Lions. And my name is Joao Ricardo Vissoci, and I'm going to present our proposal of optimizing care for traumatic brain injury using machine learning. So traumatic brain injury is one of the leading causes of death and morbidity, and this burden is extremely higher in low and middle income countries where most of these injuries are happening. As a comparison, if we were to look at traumatic brain injury in the United States and low and middle income countries, the ratio are way higher in low and middle income countries, as well as the ability to provide care for these patients is lower, here measured by the proxy of surgeons per million people, or even for CT scanners. So there is a need to handle this scarcity of availability of care for traumatic brain injury patients. Some of our data from Tanzania has also shown the need for optimizing how resources are allocated. This graph shows a Kaplan-Meier curve for the time to event for negative outcomes for traumatic brain injury patients, and you can see that apparently there is no association with receiving a surgery treatment, for instance. And some of our other results has shown, and I'm sorry for the problem in the formatting there, that delay in reaching hospital, or lack of access, or delay in having a CT scan, or lack of access or delay in getting oxygen, for instance, are also linked to higher odds of poor outcomes for TBI patients. So the resources are needed, resources are not available, and when they are available, they might not be using properly. So the problem we found is that how we can support data-driven optimization of resources allocation for TBI patient care, especially in low and middle income countries where access to infrastructure and personnel are scarce. And the solution we've come up with is a web application that works as a decision support system for risk stratification of TBI patients. And although some of these technologies already exist, this is culturally adapted to Tanzania based on some of our preliminary data of 4 years of TBI registry in this location. And this technology is a machine learning-based algorithm that works with readily available data at patient entry to the healthcare system, given hospital, pre-hospital care, ambulances, primary care at some points, or even hospital. And as we can see from the video, you can enter the patient data to the side, and it changes patient risk stratification. For this example, I'm just showing how the risk for a negative outcome for TBI relates to receiving and not receiving surgery, but we can do that also for going to ICU, receiving some sort of airway management or oxygen and so forth. And then it can be deployed using smartphones, iPad, computer with or without internet connection. As of today, what we've done then is that we found this need, and we approached this need based on data we've already collected in this 4 to 5 years that we've been working in Tanzania. And we've developed this model that has been shown to be positively working. So testing a bunch of machine learning techniques, we're able to find a model that gave us about 84% sensitivity to identify negative outcomes with an area under the curve of 0.87. It's not perfect, but it's good to identify patients with potentially higher need for care or specialized care.
That's death?
Poor outcome. Here, combining death and severe disability. So next steps for us is to assess how this technology would work, its feasibility, and here's where we're asking support for. What's the next steps of applying this technology locally? Should we scale this up, implement in different countries and translate it culturally for other locations? Or should we implement this in Tanzania and find the best suitable application to this for first responders or for hospital-based care? And how we can come up to go live and start using this technology. We've been developing this model for Tanzania, and we plan to start doing some implementation studies later this fall. We also have a model working for Uganda, where we also have a TBI registry ongoing, and we have found interest from Brazil and India to connect this data set either to EHR systems or to pre-hospital care systems. I am leading this project. I'm originally from Brazil, but I've been working at Duke University in the Duke Emergency Medicine for the past years. I'm also affiliated to the Duke Global Neurosurgery and Neuroscience at the Department of Neurosurgery at Duke and the Duke Global Health Institute. I currently lead 2 consortiums for data science applicable to health, the Math Consortium, which is focused to analytics for health, and the GETS, which is a group that focuses on geospatial processing for healthcare as well. And I've been collaborating with Dr. Staten on KCMC, which is the Kilimanjaro Christian Medical Center in Tanzania, for the past 6 years. I've been working on data science for different approaches for healthcare in some of the work we've been doing. and I've already developed machine learning-based approaches for Brazil primary care system. And our team is composed by physicians, here represented by Dr. Stedden, which is our local a lead person in Tanzania with her group, with nurses and research assistants, as well as my colleagues, which involve computer scientists, machine learning experts, and medical students. And what we're asking for here is support on how we can find funding to take this to the next level. We've been doing this with a very limited budget at this point, and who to ask for funding, how to protect our time, the team's time, and how to make this implementation. That's it. Thank you.
Okay. What's that? All right, this is Jeff Klein, and I do research. All right, so I've done a good bit of work with AI, Bayesian nets, and pulmonary embolism. So the first question I have to ask you is this just better than a doctor? Doctor looking at the patient and saying what the probability of death is or bad outcome. So tell me if it's better than that.
Yeah, that's what we're trying to do this next fall.
Okay,
but I don't think we want to get to that point specifically. We don't think that this could be used as an independent tool. It should be used as a support for, I've heard my colleagues talk a lot about this, about how this can increment physicians' gestalt too.
Okay, so it's an augment, sort of supplement.
Yes.
All right, let's say it makes it better, a little bit better. How's it going to change that hazard curve by, knowing who's going to die? You're not going to change the world. Right. You're just going to change who you know needs the world. So how's it going to make things better?
So first of all, from some of our data has been showing that I think we can help optimize who receives some kind of treatment, especially in these areas where treatment is not readily available for everybody. So some of our results has shown that there's about 10% of people that could have received surgery in that specific study that did not receive based on our...
So there is mistriage where there could have been lives saved.
But I think that in discussing with our colleagues, the best application for this would actually be for stratifying risk of where to take patients mostly, putting this on
Tell me about your training set. Where did you get the training set from? You said you had a database because that's really, it's only as good as the set you had.
Yeah. So this
tell
is
me about the collection of it, who collected it.
So this is a traumatic brain injury registry that's been going on at KCMC in Tanzania, and it's been going for the past 4 to 5 years. And it's collected by research nurses at the location who have been trained by Catherine Staten in this project for the past...
and how many humans are we talking about would be affected by this roughly with brain injury? Are we talking 10,000, 20, 100?
Well, that specific number is impossible to capture in Tanzania because we don't have
roughly. I mean, 10 or 1,000?
Well, we've been collecting about 800 to 1,000 patients a year.
Okay. So, all right, well, I'm interested in this technology, and I think that it has, I said you can't change the world. I want you to change the world. I really mean that. So, I'm going to come out and, let's see, how are we doing?
You can offer whatever you want, Jeff.
Okay, so I think one of the things that happens with global emergency medicine is it doesn't have the best home to publish. And I don't really like academic emergency medicine to be the home for a lot of global medicine because I get the paper and I can't even read it because it's, English is a second language for one thing. But, when you derive your, let's say, your initial training set, I'd like to see the paper. I don't have any money to give you right now unless Megan gives me money to give to you. But, so I don't have any money to give to you. And then it will be a methods paper, and then that means I'll give it to Craig Newgard to do all the work on. No, I'm kidding, Craig. I won't do that. I think I would love to see a paper from you that's the derivation and have a chance to at least review it.
Hi, Don Neely from University of Pittsburgh. Interesting work. So mine is I have some exposure in decision support, not so much in artificial intelligence. My piece of advice purely from seeking funding and moving forward is it's important that you paint the big picture, and I think Jeff asked you a few questions about what's this going to do eventually. There has to be an end game. But you're really focusing right now, it looks to me, on feasibility, and the feasibility is, can I get this seemingly high-tech approach in a decidedly low-tech environment? And so I actually think you have to reframe the proximate ask into feasibility. what devices we're going to use, where we're going to use them, the information, and not so much worry about the machine learning part yet. That's downstream. I mean, what your next ask is, can I do this more broadly in that setting? Can I collect information, and then the information will be fed in? And so I see that as the biggest gap here. Without that kind of honing, I'd say, you know, if I was a reviewer on a grant, I'd say, you know, interesting idea, but they don't really get each of the steps. You can't run until you've actually crawled first, and you're actually still trying to crawl here. This isn't my area of expertise. You should take Jeff's offer up about the paper. I sit on the analyst side, and I don't think they're going to want a methodology paper, so I can tell you that pretty clearly. But I think you're on the right things, but step by step. It's a great novel idea, but you have to show that you have the first and second steps well thought out so that they, you know, things go in progression.
This is Vic Babardo, University of Colorado. So is the intent of this long-term is to stay in these more austere environments, or is to translate into, because as you said, especially in many parts of Africa, this prolonged pre-hospital care hours, right, without a lot of care. The medics are more fundamentally trained, not like they are in industrialized areas. With these TBIs, if oxygen provides a lot of support, if they're severely hypoxic, there's no oxygen for many, many hours. It's a different setting. So is the idea to keep it in these settings, and this in your plan for future study, for future funding in this global health network, or to come out to industrialized areas?
So initially, we're using this as an innovative platform for global health because that's where I feel more comfortable working on. But we've had some asks for bringing it to Duke specifically, and we're discussing how to best use this technology in a higher developed country because the challenges are different. So it's easy to see an application of this to a very low resource scenario, but a high income country or a high developed location, the challenges would be more complicated. So finding the exact clinical application is something that we've been working. I'm very limited to that as I'm just a PhD and not an MD, but we've been discussing this with Catherine and some of the other folks at the Duke Emergency Medicine to see how to best approach this.
I don't do global health, but I do work with some folks who do. I think one of the troubles of global medicine is getting funding for this type of work. But
Right.
there is a U.S. agency that does fund this type of thing because you've got prolonged field care, you've got areas of trauma, TBI in particular, you've got fundamental medics who don't have care around them for a while. And that's the Department of Defense, and I work a good bit with them. They are interested in this type of thing. So I can't help you with a paper, but I could potentially help you with contacts to discuss this. Now, the application, especially being used in the WebNet and whatever vehicle they're driving those guys in for 9 hours to a hospital, I'm not so sure about, but this fundamental concept around this type of thing, prolonged field care is a big thing for them, traumatic brain injury is a big thing for them, that there could be some value there.
Okay, that's great.
Yeah, my name is Craig Newgar, and I'm coming from Oregon Health and Science University. So I like the presentation a lot. I like the concept. I guess I'd want to make sure that this had been validated and better than, kind of following up Jeff's comment, better than a physician gestalt. You know, it's like if it's not better than someone looking at the patient or medic or field provider, then, you know, doesn't have a lot of traction. And also there's a lot of issues with developing clinical decision support from, say, trauma registries or data sources that collected data on more severely injured patients that may or may not apply to the broader population that's seen in the field. I think that this, other than the DoD, that Fogarty grant could be a good match for this as well, for global health. And I think you have what sounds like several potentially good offers for mentorship. I would be willing to mentor you for this project as well. Basically coming from the side of, I do trauma research, I do EMS research. I haven't done a lot of global health, but I've spent some time in these settings, and I think that there could be some traction with this project if it's done right. So that's an offer for you in addition to what you've heard so far.
We have 2 more minutes. Do you guys, Joao, do you have questions for them, or
Yeah.
in terms of sorting out the offers or trying to get them to combine?
Well, I appreciate it. I actually don't know what's the process here. I appreciate all the offers.
However, you could in theory accept, usually we tell people that they can accept 1 offer.
Okay.
So you either have to get them to come together into an offer, or
Okay.
you get to work that out.
Okay. What I would say is this project is on a preliminary phase, so the validation piece is really needed, and support to that point is really needed as well. I appreciate all the offers, and I would love to find a way that we can combine some of them, especially because we are thinking of a grant proposal and then putting together a steering committee or an advisory board for this proposal would be an
Yeah,
excellent
the best
perspective.
thing that I could tell you is if you send the paper to me, Craig and I can get together. I can get Andy Novobilski to review your neural network model. He's the director of artificial intelligence at University of Tennessee, Knoxville. We can put together people that are going to tell you what you're going to see in your grant review. You're not ready for a grant. You send it in if you want to, but
Right,
it's
right.
you know that's probably the best offer you're going to get is in reality to get some careful mentoring and thought before you construct an application. And by the way, who are you working with in Tanzania? Because there's a lot of people that are down there in Tanzania and Dar es Salaam. Do you know Mike Runyon by any chance?
Who?
Mike Runyon?
I probably don't, but I'm working with Catherine Statham, who's leading the whole emergency medicine, the global emergency medicine working
Yeah.
at KCMC in
Yeah.
Moshi, and
Interesting.
she probably does.
Catherine, do you have a way in terms of these offers?
I think that I'm a legend lead. I've been on the center and I think I've done a wonderful job of this. When it comes to suggestions, I think you guys are right. We're moving in the right direction. We're going to validate it first and after that, so I'll let you run with it.
Yeah.
The only thing I do want to add was some of the discussion of we are focusing this as being such a tool for people who don't yet have the capacity or learning the knowledge that we have here. So that was the only thing I wanted to add. Most questions are covered.
I mean, yeah, definitely, that would be great. I appreciate the offer, and we have a paper pretty much ready that I can send out and can start discussion about that.
Awesome. All right, well, thank you.
Thank you very much. Yes.